Good morning, everyone. Welcome to the Journal Club for September. I hope everyone is well. The first study is a randomized trial published in Gastroenterology by Carino et al. It's titled Endoscopic Ultrasound-Guided Final Biopsy with or Without Rapid On-Site Evaluation for the Diagnosis of Solid Pancreatic Lesions, a randomized controlled non-inferiority trial. US-guided final aspiration is the gold standard for the evaluation of solid pancreatic mass lesions. However, US FNA has some limitations. These include the fact that the diagnostic sensitivity of US FNA is dependent on the availability of rapid on-site cytopathology evaluation, also known as ROSE, which is not universally available. The diagnostic yield of cell block procured using an FNA needle is often suboptimal for ancillary studies. The diagnosis of morphologically challenging lesions may require retained histological architecture for definitive diagnosis, which FNA often do not provide. Cytological specimens from FNA aspirates lack desmoplastic stroma that may be necessary for molecular profiling, and not all pathologists are equally proficient in interpreting cytological samples. Therefore, in order to try and circumvent these limitations with US FNA, newer generation needles known as FMB needles have been developed to try and circumvent this limitation. There are four main FNB needles currently available. These include the Fransing tip needle. This is known as Acquire. The fork tip needle, here in D, this is known as Charcot needle. This is reverse bevel tip needle, which is the Procore, and this is the Mengele tip, which is the Olympus Easy Shot. Now, FMB needles have been shown to acquire histological core tissue in previous studies, and hence may obviate the need for rapid on-site evaluation, allow immunohistochemical studies to be performed more easily, and allow molecular profiling. So the aim of this large randomized trial was to evaluate the benefit of ROSE in US FNB. So this was a multi-center randomized trial conducted in 14 centers in 8 countries. This is a non-inferiority trial where the authors hypothesized that US FNB without on-site evaluation was non-inferior to US FNB with on-site evaluation for cytology. And the non-inferiority margin was decided at 5%. All patients with solid pancreatic mass lesions were enrolled. It was a one-to-one randomization where one group underwent US FNB without rapid on-site cytopathological evaluation, and the second group underwent US FNB with the presence of an on-site cytopathological evaluation. For choice of the FNB needle, 3 different types of needles were permissible in this study: the Fransing fork tip and reverse bevel tip, and the technique of FNB was left to the discretion of the endoscopist, although they do state that in all cases, fanning technique was utilized whenever possible. The primary outcome measure was to look at the diagnostic accuracy at 6-month follow-up. So this is the consult flow diagram showing the study enrollment. Essentially, 800 patients were randomized, 400 to FNB with ROSE, and 400 patients to FNB alone without ROSE. And essentially, after exclusion of 15 and 14 patients in each arm respectively, subsequently, 385 were enrolled in the FNB with ROSE group and 386 patients in the FNB alone group. So this is the primary outcome, diagnostic accuracy. And as you can see, the diagnostic accuracy in the FNB with ROSE group was 96.4% compared to 97.4% for the US FNB without ROSE group, with a p-value of 0.396. As you can see, the difference in diagnostic accuracy between these two groups is 1%, and therefore it can be determined that EOS FMB without rows is non-inferior to EOS FMB with rows. These were some of the other secondary outcome measures. As you can see, there was some difference in the procurement of histological core tissue, which was actually higher in the EOS FMB alone group compared to EOS FMB with rows. And also the procedure time was significantly shorter in the group without rows. These are some of the limitations of this study. Some pathologists in the study, the authors state, had limited experience with touch imprint cytology technique, which is a technique used to make slides for on-site evaluation in when procuring histological core tissue with FMB needles. And therefore, they do state that this may have led to some possible bias in favor of EOS FMB without rows. Now, all centers were highly specialized, which does in some degree limit the generalizability of the study results. And also the choice of the FNB needle and the technique adopted during EOS FMB use was left to the discretion of the performing endoscopist. So in conclusion, in EOS-guided tissue acquisition of solid pancreatic mass lesions, EOS FMB without rows when performing 3 passes was non-inferior to EOS FMB with rows. Therefore, EOS FMB should become the standard of care when sampling solid pancreatic mass lesions, especially in centers without rapid on-site cytological evaluation. Our second study looks at different techniques for removing large cell-saturated lesions. This was a retrospective study across 2 successive periods. This is published in Gut by Van Hattem et al. Large cell-saturated lesions, so greater than 2 centimeters in size, are premalignant lesions that occur sporadically or as a part of serrated polyposis syndrome and can lead to interval cancers. They are typically counted as flat lesions in the proximal colon. Endoscopic mucosal resection is known to be effective in the management of large cell-saturated lesions, however, can be associated with post-EMR bleeding and deep neural injury. Cold snare polypectomy, on the other hand, may provide a safe alternative to EMR by omitting electrocautery-induced injury. However, the data on long-term outcomes and safety are lacking. The aim of the study was therefore to compare endoscopic mucosal resection and cold snare polypectomy in the management of large cell-saturated lesions. So this was a retrospective analysis of a prospectively collected data set in Australia. Data were collected from 4 centers. They looked at all cell-saturated lesions removed between July 2008 and January 2020 of patients undergoing endoscopic resection for large cell-saturated lesions. Now, they looked at 2 groups. They looked at patients who had undergone endoscopic mucosal resection between 2008 to 2016, and those undergoing cold snare polypectomy from April 2016 to 2020. Follow-up colonoscopies were performed at 6 months and 18 months post-index resection per protocol. The primary outcome measure was to compare the technical success between the 2 techniques. So these are some of the characteristics of the patients and lesions removed. 121 patient lesions were removed using cold snare polypectomy technique, 353 using the endoscopic mucosal resection technique. Patients were generally younger in the cold snare polypectomy group, but the sizes of the cell-saturated lesions were generally larger in the EMR group. As you can see, 25% of lesions in the EMR group were greater than 3.5 centimeters. And also, as you can see, 3% of patients undergoing cold snare polypectomy had been resection of these lesions had been previously attempted, and compared to 7% in the EMR group. These are the technical outcomes. As you can see, there was no difference between the two groups in the technical success, i.e. the ability to actually resect the lesion, 100% in the cold snare polypectomy group and 99% in the EMR group. However, a greater rate of en-bloc resection was achieved with the EMR group, and virtually no patients were able to, no lesions were able to be removed en bloc with cold snare polypectomy. There was also no difference in procedure time. This is where I think the results become very interesting. If you look at these adverse events in the cold snare polypectomy group, basically there were no adverse events, including post-endoscopic resection bleeding, intra-procedural bleeding, deep mural injury, and delayed perforation. And as you can see, up to 5% of post-EMR bleeding is seen in the EMR group, and this difference is statistically significant. These are the limitations. It is the data are derived and the results are derived from a prospective collected database study, from a prospectively collected database and the retrospective analysis of the database, and is not a randomized trial. Submucous injection, the authors state prior to resection, was not uniformly performed in the cold snare polypectomy group, and procedures were obviously performed in expert centers only, which again may limit the generalizability of these study results. So the conclusion and the take-home point from this study is that cold snare polypectomy in the management of large cell-striated lesions appears to be safer and equally efficacious when compared to traditional endoscopic mucosal resection, with no procedure-related bleeding or deep mural injury observed in the study cohort. Our first study looks at bleeding risk and mortality associated with uninterrupted antithrombotic therapy during PEG placement. This is published in the American Journal of Gastroenterology by Tosani et al. PEG placement is commonly performed and is considered a high-risk procedure for bleeding. And per ASG, they do recommend interrupting antithrombotic therapy or bridging with short-acting anticoagulation in patients undergoing procedures at high risk of bleeding. Therefore, antithrombotic therapy is often interrupted prior to PEG tube placement due to the potential risk of procedure-related bleeding. And complication rates for PEG placement have been reported in the range of 4.9 to 10%. However, the data on the actual bleeding risk in patients undergoing PEG placement while on uninterrupted antithrombotic therapy are lacking. The aim of this study was therefore to evaluate the risk of bleeding and overall mortality in patients undergoing PEG placement on uninterrupted antiplatelet or anticoagulation therapy. So this was a retrospective study conducted at a single tertiary referral center in the United States. Data collection was conducted via a retrospective chart review. All consecutive patients undergoing PEG placement from July 2010 to May 2016 were included. In the study, significant bleeding was defined as post-procedural bleeding from the PEG site, requiring blood transfusion and or surgical or endoscopic intervention. So eventually, they identified 1,540 patients who underwent PEG placement while on uninterrupted antithrombotic therapy. Antiplatelet therapy that these patients were on included aspirin and clopidogrel, and anticoagulation therapy included heparin, warfarin, and short-acting direct oral anticoagulants. And these are the study results. As you can see, only 6 incidents of significant bleeding was observed in the study cohort, and this all occurred in patients receiving subcutaneous heparin. When looking at the overall adverse events, Mortality rate of all-cause mortality in patients receiving PEG was about 8%. PEG-related mortality was, however, only 0.3%. The major complications included significant bleeding in the 6 patients that I mentioned earlier, which amounts to 0.4%. And also other major complications included the dislodgement or pulling out of the PEG tube, PEG site infections of 2%, perforation rate of 0.19%. The main limitation of the study is that it is a retrospective study conducted at a single center. Patients not on antithrombotic therapy undergoing PEG insertion was not included, so there was essentially no control group, and variability between operators was not factored into in the data analysis. So the take-home point from this study is that PEG placement is a safe procedure with a low complication risk and minimal risk of significant bleeding, even in patients on uninterrupted antithrombotic therapy. Therefore, uninterrupted periprocedural antithrombotic therapy for PEG placement appears to be a safe option in patients at high risk of thromboembolic events. Our next study is a randomized trial from Nature Medicine. It's a study conducted by Harrison et al. Looking at a novel treatment called efruxifermin for the treatment of NASH, non-alcoholic steatohepatitis. So non-alcoholic fatty liver disease is associated with obesity, metabolic syndrome, dyslipidemia, and type 2 diabetes. NASH, non-alcoholic steatohepatitis, is a progressive form of NAFLD and is defined as more than 5% of hepatic steatosis with inflammation, ballooning hepatocytes with or without fibrosis. And currently, there are no approved treatment for NASH. FGF21 is a molecule that activates FGF receptors and is a key regulator of whole body and individual organ metabolism and improves metabolic status in preclinical models of obesity, diabetes, and NASH. And efruxifermin is an agonist for FGF receptors. The aim of this randomized trial was therefore to evaluate the safety and efficacy of efruxifermin in NASH. So this was a phase 2 placebo-controlled randomized trial conducted at 24 sites in 80 patients with NASH. Patients are divided into or randomized into 1:1:1:1 ratio into 4 groups: placebo, and then one of three doses of efruxifermin, 28 milligrams, 50 milligrams, and 70 milligrams. The treatment is given as subcutaneous therapy once a week for a period of 16 weeks. Now, these are the baseline characteristics. As you can see, 21 patients were enrolled in the placebo group, and then 19 in the 28 milligram efruxifermin group, 20 patients in the 50 milligram efruxifermin group, and 70 milligrams, and 20 patients in the 70 milligram efruxifermin group. As you can see, when looking at the hepatic fat fraction, which is conducted by MRI, proton density fat fraction, as you can see, there is similarity across the hepatic fat fraction across the 4 groups, 6.9% in the placebo, and then 8.1, 6.3, and 6.3% in each of the 3 doses of efruxifermin. When looking at the fibrosis score, about 1/3 or just over of patients had F1 fibrosis, and about 2/3 had either F2 or F3 hepatic fibrosis. Now, this is the primary outcome, which was looking at the change in hepatic fat fraction in the 4 groups. And as you can see, there was a significant improvement in both the absolute hepatic fat fraction and relative change in the hepatic fat fraction with efruxifermin across all the 3 doses when compared to the placebo group. So with the when looking at absolute change, it appears to be dose dependent. And as you can see, there was a greater than 10% decrease in the hepatic fat fraction at 28 milligram dose, about 12% in the 50 milligram group, and nearly 15% decrease in the 70 milligram efruxifermin group. And these are the secondary outcome measures, which included reduction in hepatic fat fraction by more than 30% at week 12, reduction in hepatic fat fraction by more than 50% at 12 weeks, and hepatic fat fraction less than 5% at 12 weeks, and change in ALT at 16 weeks. And as you can see, when compared to the placebo, where there was virtually no change in hepatic fat fraction or decrease in ALT, when looking at efruxifermin, there was a significant improvement in all of these factors with efruxifermin at all of these doses used at 28 milligram, 50 milligram, and 70 milligram doses. Especially when you're looking at reduction in hepatic fat fraction by more than 30% at 12 weeks. As you can see, in the 28 milligram group, 52% of patients achieved this goal, 57% of patients in the 50 milligram group achieved this goal, and 75% of patients in the 70 milligram group achieved this goal. Sorry, I misspoke. 84%, 85%, and 75% of patients in these different groups achieved this goal of hepatic fat fraction reduction by more than 30%. These are some of the adverse events. Now, there was some incidences of adverse events. Interestingly, they were also seen in the placebo group of 76% and ranged from 90 to 95% in the efruxifermin group. Though, as you can see, life-threatening or severe adverse events were uncommon. Some of the adverse events observed included diarrhea, nausea, vomiting, abdominal pain, injection site erythema, increase in appetite, nasopharyngitis, and upper respiratory tract infection. This is the limitation of the study. Number one, it was a small sample size, only about 20 patients were enrolled in each group. There was a high proportion of patients with fibrosis stage F1, about 1/3 in fact, who are actually susceptible to spontaneous resolution of NASH. Also, calorie intake and energy expenditure were not controlled for in this study. So the take-home point from this study is that this compound known as efruxifermin significantly reduced liver fat and was generally well tolerated in NASH patients with F1 to F3 liver fibrosis. Efruxifermin therefore has the potential as the first-line therapy for patients with NASH. Our last study is from the Dutch pancreatitis group and is published in Gut by authors Kim Peniers et al. It looks at pain patterns in chronic pancreatitis. So pain in chronic pancreatitis is extremely common and occurs in 80 to 90% of cases of patients, and is classified into generally intermittent pain or continuous pain. The authors wanted to test the hypothesis that the different pain patterns seen, so continuous and intermittent, are different entities regarding patient demographics, imaging findings, and long-term clinical course. So this was a longitudinal study taking data from the Dutch Chronic Pancreatitis Registry. And this registry collects data on patients with chronic pancreatitis in 30 centers across the Netherlands. Questionnaires are given to these patients at the time of study inclusion, and then yearly at follow-up. And then medical records are also reviewed by the study coordinators or nurses. The median follow-up of these patients in this registry is 47 months. So as you can see, in their registry, they had 589 patients who had continuous pain from their chronic pancreatitis. 231 patients had intermittent pain from their chronic pancreatitis, and 311 patients with chronic pancreatitis in this registry had no pain at all. If you look at comparison of some of the different baseline characteristics in these patients with chronic pancreatitis and the different pain patterns, as you can see, more severe pain scores were reported in the continuous pain group compared to the intermittent pain group, with p-value of less than 0.01. If you also look at the quality of life, it's also lower in the continuous pain group compared to both intermittent pain group and the no pain group. As you can see, 37% of patients in the continuous pain group were already on strong opioids, compared to only 16% in the intermittent pain group and 1% in the no pain group. Now, these are some of the features they looked at on in these patients on their imaging. And the general take-home point with this is that they really didn't find any significant differences in patients with chronic pancreatitis and continuous pain, intermittent pain, and no pain in terms of their imaging features. So across the board in these three groups, there was no difference in whether calcifications were present, whether they had enlarged pancreatic head, pseudocyst, pancreatic ductal dilatation, involvement of the common bile duct, vascular complications, whether they had duodenal stenosis or liver cirrhosis. Then they also performed a multivariable logistic regression for factors associated with change in pain pattern. And this is a table with a lot of information, but if you just focus on these areas highlighted in red, basically what this is showing is, number one, the authors state that pain pattern alternated between these three groups at least once between the pain patterns in 61% of patients. All alternations between pain patterns were associated with a VAS pain intensity score, as you can see here. And as you can see here, surgery was associated with change in pain from pain to no pain. These are the limitations of this study. There was no information on the impact of pain patterns on psychological, social, and behavioral factors were collected in the study. This is a retrospective collection of data between patient enrollment and chronic pancreatitis diagnosis. The median duration of chronic pancreatitis in patients at the time of their study enrollment was 50 months, and therefore a lot of these patients had already received pain medication and some sort of treatment for chronic pancreatitis, which may have influenced the natural disease course and also how their pain is perceived and presented. So the take-home point from this study is that in patients with chronic pancreatitis, continuous pain and intermittent pain patterns often alternated during follow-up, and there was no difference in imaging morphology between the two pain patterns. Therefore, the study suggests that continuous and intermittent pain patterns in chronic pancreatitis are not the result of distinct disease patterns or pathophysiological entities. So to recap, EUS-guided tissue acquisition of solid pancreatic mass lesions. EUS FMB without Rose when performing 3 passes was non-inferior to EUS FMB with Rose. Therefore, EUS FMB should become the standard of care when sampling solid pancreatic mass lesions, especially in centers without Rose. Cold snare polypectomy in the management of large ulcerated lesions appears to be safer but equally efficacious when compared to traditional endoscopic mucosal resection technique, with no procedure-related bleeding or deep mural injury observed in the study cohort. PEG placement is a safe procedure with a low complication rate and minimal risk of significant bleeding, even in patients on uninterrupted antithrombotic therapy. Therefore, uninterrupted peri-procedural antithrombotic therapy for PEG placement appears to be a safe option in patients at high risk of thromboembolic events. Fructose significantly reduced liver fat and was generally well tolerated in NASH patients with F1 to F3 fibrosis and has the potential as the first-line therapy for NASH. In patients with chronic pancreatitis, continuous and intermittent pain patterns often alternated during follow-up, and there was no difference in imaging morphology between the two pain patterns. Therefore, this study suggests that continuous and intermittent pain patterns in chronic pancreatitis are not the result of distinct disease patterns or pathophysiological entities. Thank you so much for joining us this month. Our next monthly Orlando GI Journal Club is on October 6th, 2021, which is the first Wednesday of October. I hope that everybody has a wonderful and safe September. Nice to see everyone again, and wishing you a really good week. Thank you so much.